If you look really closely at a modern hospital, you'll notice this kind of startling paradox.
Oh, absolutely. It's pretty obvious once you see it.
Right, because the doctors are the ones writing all the orders, but they're darting in and out of the room for maybe like 5 minutes at a time.
Yeah.
But the person who actually decides if you survive the night, the one translating this whole chaotic maze of machines and alarms into your actual care is the nurse.
Yeah, it's really the central reality of healthcare. I mean, they are the constant stationary sentinels in what is otherwise a wildly transient environment.
And from the outside, I mean, to you or me sitting in that room, it can look like they're just constantly moving, like they're just checking boxes on a clipboard, running from room to room based on pure instinct.
Which is completely understandable. It looks like managed chaos.
Exactly. But today we are looking at a snack of sources. We've got medical texts, nursing theory, historical documents, and they reveal this hidden, mathematically rigorous engine driving every single move they make.
Yeah, and what we're actually looking at here is a framework borrowed directly from general systems theory, which, if you're not familiar, is just the idea that you can't look at isolated parts. You have to look at a complex system interacting with its environment.
Right, like the whole picture.
Exactly. It relies on continuous feedback loops to maintain stability. And when you apply that to clinical decision-making, it provides this deeply structured logic that keeps patients alive when, time is incredibly short and conditions are changing by the minute.
Okay, let's unpack this because our mission for this deep dive is to uncover something called the nursing process, specifically a framework known by the acronym ADPIE.
ADPIE.
Yeah, ADPIE.
hmm
And our goal is to show you how this isn't just dry medical jargon, it's a rigorous, literal, life-saving loop of critical thinking.
It really is.
But before we get into what the actual letters in ADPIE stand for, we need to talk about how the very definition of nursing care had to fundamentally shapeshift over the last few decades to even, make this framework possible.
And that shape-shifting is vital context. I mean, without understanding how radically the profession changed, the acronym just looks like some corporate management tool forced onto healthcare workers.
Yeah, totally. Because when I first looked at this framework, my immediate thought was to compare it to, a mechanic's diagnostic checklist for a broken car.
Oh, sure. That's a super common assumption.
Right, like you bring the car in, the mechanic checks the oil, checks the tire pressure, ticks off a to-do list, and fixes the broken part. I assumed the nursing process was basically just a standardized to-do list to get through a 12-hour shift.
Well, what's fascinating here is that historically your mechanic analogy wouldn't have been too far off.
Wait, really?
Yeah, early on it was. But today, viewing human care through the lens of a static machine checklist completely misses the reality of biological systems. The nursing process actually went through 3 massive theoretical shifts to get where it is today.
Okay, so what was the first one?
The first was moving away from that linear model to a cyclical one. Back in the early 1950s and 60s, textbooks treated nursing care as a one-way street.
Meaning you just go from point A to point B and stop.
Precisely. You assess the patient once, you diagnose the problem once, you create a plan once, and you are done.
Kind of like climbing a staircase. You reach the top floor and your job is finished.
Right, but human bodies aren't static.
Right.
I mean, a medication given at 8 a.m. completely changes the body's chemistry by 9:00 a.m.
Well, it's true.
So by the 1980s, theorists redrew the entire model as a continuous circle. The final step of the process evaluation isn't the end of the road anymore. It acts as a mandatory feedback loop.
Oh, so it pushes you right back to the beginning.
Exactly. It's a re-entry point directly back into the first step. You are never actually done as long as the patient is in that bed.
Okay, that structural change makes total sense for a dynamic biological system. But shifting from a line to a circle doesn't automatically solve the problem of, what the nurse is actually trying to achieve, right?
And that brings us to the second major shift, which was moving from a task-based framework to an outcome-based framework.
Task to outcome, got it.
Yeah. Older versions of nursing heavily emphasized the physical tasks a nurse performed. Like the central question was always, did I take the vitals? Did I administer the medication? It only measured the nurse's output.
Right.
But contemporary theory reframed that entire philosophy around the patient's outcomes instead.
So it shifted from, say, a teacher asking, did I teach the math lesson, to did the students actually learn the math?
That is a perfect way to look at it, yes.
Yeah.
The metric of success is no longer the completion of a checklist. The metric is whether the patient's condition measurably improved against a highly specific goal.
Which is much harder to prove, I'd imagine.
Very much so. But it tracks with a broader move in medicine toward evidence-based practice. There's even this massive standardized classification system now called the Nursing Outcomes Classification, or NOC.
NOC.
Yeah, and NOC literally forces nurses to measure if a patient is actually getting better using standardized indicators rather than just, vague subjective feelings like they seem fine.
But honestly, implementing something as rigorous as standardized outcomes across the board requires a lot of authority.
Mhm.
And our sources highlight that this transition from simple tasks to complex, measurable outcomes, it didn't just happen because someone wrote a new textbook.
No, not at all. It was a fight.
Yeah, it was born out of this fierce rebellion for professional independence. But wait, before this existed, were nurses genuinely just viewed as extensions of the doctor? Like just executing orders without any independent judgment?
Pretty much, yeah. The clinical hierarchy of the mid-20th century was remarkably rigid. Nursing care was almost exclusively physician-directed.
Wow.
A doctor would write an order, administer this drug, change this dressing, and the nurse was expected to just execute it. They did not have a codified, independent framework for their own clinical judgment.
So they were just hands, essentially, not brains.
That's how the system treated them. The nursing process emerged specifically to push back against that, to establish nursing as an autonomous, intellectually rigorous profession with its own distinct legal and diagnostic authority.
But how does a profession entirely subordinate to physicians manage to carve out its own independent diagnostic taxonomy? I mean, that requires a massive shift in power. Who are the people actually pushing for this?
Well, the paradigm shift really began in 1955 with a nurse theorist named Lydia Hall.
Okay.
She was the first to formally describe nursing not as a series of delegated chores, but as a deliberate process of observation, administration, and validation. She basically planted the flag that nursing had a distinct intellectual component separate from medicine.
It sounds like she cracked the door open for everyone else.
She definitely did. And then in 1961, Ida Jean Orlando, who was working out of Yale University, essentially kicked it wide open.
Oh, wow, okay.
Yeah, she actually popularized the term nursing process. Orlando realized that patients were actively suffering because nurses were largely just waiting around for doctors to dictate the next move.
Oh, because the doctors aren't in the room all the time.
Exactly. She observed that if a nurse could systematically analyze their own observations and act on them independently, patient distress plummeted. Her original model was just 3 steps, though: observation, action, and evaluating the patient's reaction.
But wait, we are still 2 steps short of the 5-step ADPIE engine we use today. Where did the rest come from?
Right. So Dorothy Johnson expanded it to a 4-step model in 1959. But the true turning point, the moment that finalized the ADPIE model as we know it, happened at this pivotal conference at St. Louis University in 1973.
Okay, 1973. Who was leading that?
It was led by Christine Gebbie and Marianne Lavin. That was the moment where they formally split diagnosis out as its own distinct standalone step.
Hold on. Carving out the power to legally diagnose a patient, that sounds like a massive jurisdictional turf war with the doctors.
Oh, it was a clinical earthquake. It was huge. But by claiming the word diagnosis, they weren't trying to practice medicine without a license. They were claiming authority over a different domain entirely.
Interesting.
And that conference birthed what would eventually become the North American Nursing Diagnosis Association, which we now know as NANDA.
NANDA, right. And if we connect this to the bigger picture, this wasn't just like some academic debate over acronyms.
Really not.
This gave nurses a defensible, legally documentable rationale for their independent clinical decisions. Like, it defined their scope of practice in a court of law. It proved they were assessing, diagnosing, and treating something highly specific.
Yes, which brings us perfectly to how this engine actually operates on the floor of a hospital today.
Yeah, let's get into that. Let's talk about the mechanics of ADPIE in action, specifically the difference between a medical diagnosis and a nursing diagnosis, because our sources spend a lot of time delineating those two things.
It's a very important distinction.
So tell me if this analogy holds up. If a medical diagnosis is the weather report, like, hey, a Category 4 hurricane is making landfall, is the nursing diagnosis basically a report on how your specific house is holding up to the storm?
That captures the division of labor beautifully.
Oh, awesome.
Yeah, the medical diagnosis names the pathology. It names the hurricane, right? So congestive heart failure, pneumonia, diabetes.
Right, the disease itself.
Exactly. The nursing diagnosis names the patient's unique, individualized response to that pathology. It assesses the house. Are the windows leaking? Is the foundation cracking under the stress?
Okay, let's run this through the actual 5 steps, using a clinical example from our sources. We have a 78-year-old patient who just came out of hip fracture surgery.
Perfect example.
Let's put ADPIE into action here. Step 1, the A stands for assessment.
Right. Assessment is the foundation of the entire system. It is the systematic collection of both subjective data, which is what the patient tells you, like their fear of falling or their pain level, and objective data.
And objective is what the nurse observes and measures, right?
Correct. What they observe, measure, and test.
So for our 78-year-old post-op patient, a nurse isn't just writing down, patient appears to be in a lot of pain.
No. The data collection is highly granular. They are recording a blood pressure of, say, 148/92, a heart rate of 104. The patient reports pain as a 7 out of 10, characterized as sharp and worsening with any movement.
Very specific.
Very. They note the skin is cool and diaphoretic. They also use validated, standardized tools for assessment.
Like what?
Well, they might run a Braden scale assessment, scoring the patient between 6 and 23 to mathematically determine their risk for developing pressure injuries from just lying in bed, or they'll use a more Sval scale. This specific data becomes the raw material for the rest of the loop.
Which brings us to step 2, the D for diagnosis, naming the problem. Now, the doctor already gave the medical diagnosis, which was the hip fracture. So what exactly is the nurse doing in this step?
The nurse formulates a clinical judgment about the patient's response, using that NANDA international taxonomy we mentioned earlier. And that taxonomy currently contains over 250 approved diagnostic labels.
Okay, wait, I have to push back here.
Yep.
215 different diagnoses just for how a patient responds to an illness. Doesn't that risk becoming this bloated bureaucracy? Like, is a nurse really flipping through a 250-item catalog while a patient is groaning in pain?
I know, it sounds completely overwhelming, but that taxonomy is necessary for precision.
How so?
Well, if a patient's oxygen is dropping, breathing poorly isn't a legally or clinically actionable term. NANDA forces the nurse to distinguish between ineffective airway clearance, which might be caused by mucus, and impaired gas exchange, which might be caused by fluid in the lungs.
Oh, I see.
Those require two completely different interventions to fix.
So the precision dictates the treatment. And our sources note they use a very specific format for writing these out called PES, problem, etiology, and signs.
Yes. So for our hip surgery patient, the nursing diagnosis wouldn't just be pain.
What would it be?
It would be formally written as acute pain related to surgical tissue trauma as evidenced by patient report of 7 out of 10 pain, guarding behavior, and an elevated heart rate.
Wow, okay. And I guess a different nurse could look at the exact same patient with the exact same hip fracture and add a completely second diagnosis, like risk for falls related to postoperative weakness and unfamiliar environment.
Exactly. The medical diagnosis is identical for everyone with that fracture, but the nursing diagnoses adapt to the individual person in the bed.
Which leads us directly into step 3, P for planning, setting the goals.
Yes, and these goals use SMART criteria, meaning they have to be specific, measurable, achievable, realistic, and time-bound.
Right. And this is where that alphabet soup of nursing language all kind of comes together, doesn't it?
It really does. They use the diagnosis from NANDA, they select interventions from the NIC taxonomy, that's Nursing Interventions Classification, and they set goals using the NOC Outcomes Classification we mentioned earlier, the NNN language.
NNN. Got it. So for our patient with acute pain, a SMART goal isn't just make the patient comfortable. It has to be something like, patient will report pain at a 3 out of 10 or lower within 1 hour of intervention.
Highly specific and strictly time-bound, which takes us right to step 4. I here for implementation. Action meets reality.
Okay, this is where the nurse actually gives the pain medication.
Giving the prescribed analgesic is one intervention, yes. But nursing interventions go so much further than just pills.
Like what else?
It involves repositioning the patient. Because this is a hip surgery patient, the nurse has to implement strict hip precautions. They are actively avoiding internal rotation or adduction, which could literally dislocate the brand new hip implant.
Ouch. Okay, so we've assessed the data, diagnosed the response, planned a measurable goal, and implemented the physical care. Now we reach the final letter, E for evaluation. Did any of this actually work?
The most crucial part.
Let's expand on our earlier analogy. The doctor says a hurricane is coming. The nurse says the roof is leaking. But the nurse doesn't just put a bucket under the leak and walk away for the rest of the shift.
No, the evaluation step mandates that they come back to the room in an hour to see if the bucket is overflowing.
Right.
So 1 hour after giving the medication and repositioning the patient, the nurse returns to the bedside. They reassess the subjective and objective data. And let's say the patient now reports their pain as a 4 out of 10.
But wait, the SMART goal was 3 out of 10 or lower, so the goal failed.
It did. But because ADPIE is a continuous loop, a failed goal isn't the end of the shift. The evaluation step forcibly cycles the nurse back to the A, back to assessment.
Ah, the loop.
Yes. Was the medication dose inadequate? Is the patient's anxiety exacerbating the pain? Does the care plan need to be totally rewritten? This continuous feedback loop is the mathematical safety net that catches subtle declines.
Okay, but here's where it gets really interesting for me. Because ADPIE sounds perfect in theory. It's elegant, it's rigorous, it's logically sound.
On paper, yes.
Right. But what happens when this highly academic 5-step framework collides with the chaotic, brutally understaffed reality of a modern hospital? Does forcing every single decision into this rigid, standardized box actually kill a veteran nurse's natural intuition?
You've just touched on one of the most prominent debates in nursing theory. This was spearheaded by Patricia Benner.
Okay, what did she say?
Well, in 1984, Benner published a landmark book called From Novice to Expert. She applied the Dreyfus model of skill acquisition to nursing, and she explicitly warned against the danger of what she called cookbook nursing.
Cookbook nursing, meaning like just blindly following a recipe without ever tasting the soup to see if it actually needs more salt.
That's a great way to put it. The Dreyfus model illustrates that while a novice desperately needs rigid, context-free rules, like a 5-step ADPIE checklist, just to function safely.
Right, because they don't know what they're doing yet.
Exactly. But an expert operates completely differently. An expert nurse relies on tacit, holistic pattern recognition. They don't think in rigid blocks anymore.
They just kind of feel it.
Yes. An expert can walk into a room, take one single look at a patient's skin tone, the rhythm of their breathing, the tension in their posture, and instantly sense the patient is crashing.
So they know the house is collapsing before they've even pulled out a clipboard to measure the water in the bucket.
Precisely. And critics of the nursing process argue that overstandardizing care privileges this bureaucratic documentation over that rapid, life-saving human intuition. And this ties into a known vulnerability called diagnostic drift.
Oh, right. Diagnostic drift is where 2 veteran nurses can look at the exact same objective and subjective data and select entirely different NANDA diagnoses.
Exactly. Because human experts prioritize different things based on their unique experiential patterns.
That makes sense.
Yeah, one expert might immediately prioritize the acute pain, knowing it's driving up the heart rate. Another expert might prioritize the fall risk, knowing the patient is disoriented from the anesthesia. But honestly, the deepest friction point in the real world isn't even theoretical disagreement.
What is it?
It's the sheer crushing burden of burnout and documentation.
Because proving you did ADPIE is what keeps the hospital legally accredited.
Yes, organizations like the Joint Commission constantly audit these care plans to ensure safety standards are being met. But the documentation is so extensive that nurses report spending massive chunks of their 12-hour shifts glued to a computer screen in the hallway, charting their assessments, rather than actually being at the bedside observing the patient.
Wow, that is a brutal paradox. The very tool designed to ensure meticulous, individualized care is physically pulling the nurse away from providing that care.
It is, and this raises an important question. What happens when systemic pressure becomes so immense that the core discipline of this process, the A for assessment, simply collapses?
And the sources cite a highly disturbing example of exactly this, the Mid-Staffordshire NHS Foundation Trust scandal in the UK, which blew up around 2013. And we aren't just talking about a few missed chart entries here. This was a catastrophic, systemic failure.
Yeah, it is a harrowing cautionary tale of what happens when that feedback loop is destroyed.
What actually happened?
Well, investigations found that the hospital culture became so aggressively focused on administrative targets, like emergency room throughput and financial metrics, that chronic short staffing became the norm.
So there just weren't enough nurses.
Right. Nurses simply did not have the time to perform systematic assessments. Basic hydration, pain management, and early signs of deterioration were entirely missed.
Because if you skip the assessment step, you can't diagnose, you can't plan, and you certainly can't evaluate. The entire engine just stalls out.
Exactly. And hundreds of patients suffered or died unnecessarily. It proved that ADPIE isn't just an academic decoration or, a hurdle for nursing students to clear. The rigorous discipline of gathering data and evaluating it is the literal difference between life and death.
That is heavy.
It is. But the process only functions if hospital administrators provide the staffing ratios and the time to actually execute the loop.
So what does this all mean? Let's bring us back to you, the listener. The next time you find yourself in a hospital bed, or sitting in a chair next to someone you love, and you see a nurse checking a monitor, asking specific questions about your pain, or adjusting your physical position. You now know they aren't just ticking off a random checklist. They are executing a continuous, relentless cycle of observation and feedback.
That machinery of ADPIE is always running in the background.
Furthermore, you know that when they diagnose you, they aren't looking at the disease. The doctors are tracking the hurricane. The nurse is looking at you. They are looking at your personal, unique, individualized response to the crisis.
That's the beauty of it.
Yeah, this invisible framework is the reason why excellent care feels personal rather than generic. Every time a nurse catches a subtle decline in your health before it spirals into a full-blown emergency, it isn't just luck. It's ADPIE at work.
It is the structured discipline that allows them to apply their intuition safely and effectively. But I do want to leave you with one final thought to ponder today, building on that tension we discussed earlier between Patricia Benner's cookbook nursing and the modern documentation burden.
Oh, I like where this is going.
Right now, hospitals are racing to integrate AI and predictive algorithms into electronic health records. These systems can instantly analyze a patient's data, automatically generate a care plan, and instantly suggest NANDA diagnoses.
So basically taking the cognitive heavy lifting and the charting completely out of the nurse's hands.
Exactly. The question is, will this incoming algorithmic technology finally free nurses from the computer screen, giving them their time back so they can return to the bedside and engage in true human assessment?
Or what?
Or will it push the profession into the ultimate cookbook nursing trap, where rigid algorithms quietly override the irreplaceable, holistic intuition of an expert nurse?
Wow. It's the ultimate modern tension between the efficiency of the machine and the necessity of the human touch. Because when the storm hits, you want the person assessing your house to actually be looking at the foundation, not just trusting an automated report from the Weather Bureau.